Peace be upon you and God's mercy and blessings. I am Dr. Hamad El-Sayed, and this is the Simple Neonatology channel. Last time we started a series of meetings about respiratory support. Let's continue. Let's continue this very important episode on one of the most crucial topics in neonatology and pediatrics, respiratory distress. How to support the patient with respiratory distress. Episode number 2. Welcome. Last time, we talked about two very important things. First was how to reduce the problems, and the second was also about how to reduce the problems. We divided each of these important topics, so let's continue with the respiratory distress series. The first thing we want to say this time is that we must truly know, in order to support any patient with respiratory distress, what the essential principles and steps are. With distress, you have to ask yourself an important question first. What is the aim that I want when I provide support? And if you think about this question for a bit, what is the aim you want to achieve for the patient? When you reflect on this, the answer will be very important. It will help you understand how you should proceed with patients, especially those experiencing respiratory distress. Everything we aim to achieve when we intervene with patients who have respiratory distress is centered on this. Our goal is to bring them to a state of normal respiration because it is very difficult to return them to a state that is exactly like normal. Because true normalcy is something only God can grant, but we try to get as close to normal as possible. That's why our goal is to understand the norm so we can optimize the settings as much as possible and help patients get closer to independent breathing and to understand how independent breathing is achieved. The first thing we need to know is that independent breathing begins with spontaneous breathing. The first thing is that independent breathing takes place in this way and increases something called the intrathoracic cavity. And physics tells us that if the volume of any cavity increases, the pressure inside that cavity must decrease accordingly. So when the diaphragm moves downward, and the intrathoracic cavity increases, the intrathoracic pressure decreases. As a result, air flows from the outside to the inside. Because under normal conditions, there is equilibrium between atmospheric pressure and intrathoracic pressure. Therefore, there is no flow neither in nor out. But when there is a change in one of the two pressures, airflow occurs when the intrathoracic pressure decreases. Consequently, it relatively increases. Of course, it doesn't actually increase, but it becomes higher than the intrathoracic pressure, which is the atmospheric pressure. So from outside to inside, inspiration occurs. As for expiration, the opposite happens. The diaphragm starts to move again, and after it moves, it relaxes and moves outward. The intrathoracic cavity decreases, and when the cavity decreases, it means it increases. The pressure increases, the intrathoracic pressure increases, and as a result, air moves from inside to outside, from the lung to the outside. Atmospheric, because in this case, the intrathoracic pressure becomes higher than the atmospheric pressure, and this happens during expiration. This was a summary of the mechanism of normal respiration. When they saw and understood this mechanism, they said, so if we want to help patients, we can do something simple, change the intrathoracic pressure. That is, either increase it or decrease it, so that patients can perform ventilation, whether in or out. So indeed, a long time ago, about 100 years ago, they started implementing this idea, and it was a very basic, fundamental thing, really very basic, essentially quite simple. Negative pressure around the thoracic cavity. When there is negative pressure, it pulls on the chest wall, increasing the cavity. As we said, the thoracic cavity increases, the thoracic cavity decreases, air moves from out to in, then this person returns the thoracic cavity to the normal cavity. The cavity decreases and the thoracic cavity increases, and expiration occurs. This method was used for a good period, about 20 to 30 years, and it was very effective at a time when there was something called the iron lung, and it was used for patients with muscle paralysis. These devices helped them a lot at that time, but later they started to discover that this method could cause disease in the muscles and in the chest, and could cause problems for the nerves and the pleura because you are pulling on the chest wall and the nerves, and this was not an easy matter. After that, They started to change their thinking and said that instead of changing the intrathoracic cavity, we should change the ATM, atmospheric. But how can we change the atmospheric pressure? Atmospheric, they said that we can change the atmospheric pressure by applying changes from the outside to the airway from the outside. Meaning we apply positive pressure to the nose and mouth, so it seems as if we are increasing the atmospheric pressure. So we can change the air from out to in using a pressure breather, as it pushes air from the outside in and from the inside out. And this was the big idea upon which all respiratory support is based. Positive pressure ventilation, which is the foundation of all respiratory support. It is based on this concept that we apply pressure to the respiratory system from the outside on the nose and mouth. Then the pressure pushes air from the outside to the inside, and then we release the pressure, so the air exits during expiration. This was the fundamental idea upon which all respiratory support is built. The second point we want to talk about is flow. We said that flow is one of the important and often overlooked things, and it has been neglected a lot because many people don't know about it and many people don't understand it. So it was necessary to clarify it. Flow is what moves. When something moves, it is called flow, which is why it is volume per time. So what is its importance? Flow gives us the shape and character of the volume. Previously, the last time when we gave a patient a nasal cannula, we said that in neonates, what would the maximum flow be? And we asked this question, what does it mean? And we didn't answer it. I hope you looked it up and found the answer because it will help us a lot. Why is it that even in pediatrics, when giving 2 milliliters per kilogram in neonates, we don't give per kilogram whether it's 1 to 8 or 1 to 2 to 3 to 8? But we don't look at this issue because of the kg, because the age of the neonate or the weight of the neonate is within a limited range, meaning most of them are around 2 kilograms, maybe from 1 to 3 kilograms within these limits. So the age or weight factor in them doesn't change significantly, which is why we keep the flow fixed regardless of weight. Okay, for pediatrics, we typically give 2 liters per kilogram of body weight when administering fluids. Why is it specifically 2 liters per kilogram in pediatrics and not the same in neonates? This is actually one of the most important things we understood and learned in physics, especially when it comes to fluid dynamics and how fluids behave in different bodies. If you introduce pediatric flow or fluid into a certain tube, for example, they say, air can be determined in 2 ways. Air can be determined in 2 ways depending on the method used. Air can be determined in 2 ways, and understanding both is crucial for proper assessment. Air can be determined in 2 ways. 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 Air can be determined in 2 ways, and what passes through the tube. Will it move in a linear way or will it move turbulently? What is important in this story, what matters to us, is to understand that when air moves through the tube and flows downward, the resistance here will be very low. What does this mean? It means that the work needed to move this flow through the tube will be minimal. Therefore, if we apply this to respiration, we will find that the entire respiratory system is basically a tube with air flowing through it. So if we move air through this tube, in fact, the work that the flow will do for patients to reduce the process of restriction, you'll find that if you give a high airflow, it will move faster and become turbulent, and therefore the work that the flow will do for patients to reduce the process of restriction will be high. So you will increase the work of breathing. In reality, you might tire the patient out if you give them an intermittent flow. You'll find that flow is neglected even in the ventilator, because when we adjust the ventilator settings, we have to set the flow as well. But the RT should also be set at 8, yet we don't really know how neglected it is or in what way it's neglected. No one really talks about flow in general. Nowadays, there's something called variant flow, which means the ventilator itself can determine the appropriate flow for the amount of volume entering, and it can choose the right flow for the volume so you can move in layers. The second point we mentioned last time was that one of the machines we use to deliver pressure is called a PSI BAP. We said BAP means positive airway pressure, and we asked, what does PSI mean? And we left this for you to think about a little, but I hope you've come up with some answers. But PSI, capital S, capital I, means synchronized. The S and I stand for synchronized inspiratory. CPAP is short for synchronized inspiratory positive airway pressure, because this machine, the CPAP, is one of the few machines that has synchronization. Very few machines have synchronization, meaning they have a probe or a detector sensor. We can attach it to the skin so it can detect when the patient is inspiring or expiring. So when the machine gives inspiration, it provides synchronized inspiration, meaning it matches the patient's own inspiration. So we try to reduce the possible conflict that could occur between the machine and the patient. For example, the patient might be exhaling while the machine is giving inspiration. So the machine giving inspiration at that moment is one of the important things in achieving synchronization. And that's why it's called synchronization. It's called CPAP, which stands for Synchronized Inspiratory Positive Airway Pressure. These were some of the points we discussed about future assistance, and we will continue, God willing. In the upcoming sessions, we will continue the series on future assistance in neonates. And in pediatrics in general, I hope these sessions are beneficial, because that's why we're doing them. Share them with our friends. I hope I was able to help you. Thank you. Peace be upon you, and God's mercy and blessings